The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you for joining us again today for another opportunity to listen and learn from the experts. And today we are extremely fortunate to have Dr. R.Williams as a guest. Dr. Williams will be educating us all about clinical decision making and his treatment algorithm for articular cartilage. I am Christian Besner with JRF Ortho. I'll be doing just a moment or two of housekeeping and then reading an introduction for Dr. Williams and turning control over to him then. Everyone on the webinar has entered in listen-only mode. You should see on the right-hand side of your screen or upper right-hand corner a dialog box for questions. Please feel free to enter any questions that you have throughout the presentation. And I'll monitor those and feed those along to Dr. Williams as we're able to. So our guest again today, Dr. R.Williams, is a specialist in the field of shoulder, knee, and elbow surgery at Hospital for Special Surgery. Dr. Williams holds a dual appointment in both the Department of Orthopedic Surgery as a full-time member of the Sports Medicine and Shoulder Service and as a clinician scientist in the research division. He is also a professor of orthopedic surgery at Weill Cornell Medical College. Dr. Williams attended college at Yale University and medical school at Stanford University. Dr. Williams did both his orthopedic surgery training and sports medicine fellowship training at the Hospital for Special Surgery. His clinical and research interests include cartilage regeneration, cartilage transplantation, arthroscopic ACL, arthroscopic rotator cuff repair, arthroscopic shoulder stabilization and labral repair, posterior cruciate ligament reconstruction, elbow ligament reconstruction, and partial knee replacement. Dr. Williams is the director of the Institute for Cartilage Repair at Hospital for Special Surgery in Manhattan. He currently serves as the medical director for the Brooklyn Nets and the New York Red Bulls. He's also the head team physician for the Iona College Department of Athletics. Dr. Williams is an avid cyclist, runner, triathlete, and golfer. Dr. Williams, thank you again for joining us today. I'm going to go ahead and throw control over to you. And that looks great. Thank you.
Are we good? Great. Can you hear me? Awesome. Great. Well, thanks for having me. So I was asked to go over sort of what my sort of thoughts are in 2020 with regards to decision making. And if any of you have heard me speak before, I usually try to come at it from the standpoint of high demand athletic individuals. I have a practice that's primarily a knee practice that has a high focus on kind of year-round athletes, high demand elite level athletes who are just looking to train and to prepare for their sport on a year-round basis. And as such, I'm always looking for the most durable of options in the cartilage repair realm. So, so give me 1 second here. There we go. So we can start with this case study. So this is an elite level basketball player, collegiate player, who in the course of normal play kind of came down awkwardly after layup and experienced immediate pain and swelling and inability to ambulate, and was diagnosed with this shear injury off of the lateral femoral condyle, measuring about 20 by 20 millimeters, big loose body there, as well as you can see in the top left-hand picture some lateral meniscus pathology as well. So as it was an in-season injury, at the time we decided to not go forth with a big reconstruction. He had some sort of post-collegiate aspirations, and as a result, we decided to just do a palliative procedure. So I did a knee arthroscopy, removal of loose body, and just simply at the end of the case injected some bone marrow aspirate concentrate into the joint, with the thinking that we would get some imaging studies done at a later time to see what the lesion looked like and to possibly go forth with some sort of autograft in the future. So So here are the intraoperative pictures as well as the preoperative sagittal MRI, and you can see that 2 years later, this player continues to play professionally and maintains some lesion fill, which most of us would agree looks like a well-done microfracture with a fairly homogeneous looking fibrocartilage layer over the area in question. So what did this tell me? The more experience I obtain in this area, the less I feel I know. And we need to really start thinking about some of our biologic options, I think, as we move ahead. So things to think about with regards to returning to play after cartilage injury, you can break down to a couple parts. So number one is we clearly need to be able to restore the functional anatomy of the area that we're treating, meaning that because cartilage has a low intrinsic repair capacity and the conditions for cartilage synthesis do not exist ex utero, we need to be able to create some functional tissue there. And unfortunately, we don't have any validated treatment algorithms, nor do we have evidence that we can create functional articular cartilage in an adult. And secondly, and this is where I think we are in 2020 as opposed to in 1998 when I was just getting started, you know, the functional tissue restoration was really the thing. Now I think we've got plenty of options which allow us to create tissue in an area of defect. Now it's, you know, essentially how does one manage the joint itself, the envelope, the chronic inflammatory response which take holds in this area that can make loading these joints even after cartilage repair very difficult and challenging. Basically, what are the best strategies that we can employ to decrease or eliminate the synovitis that tends to accompany these lesions? They typically are chronic lesions, and as a result of the perpetual shear and generation of disparate cartilage pieces and just basically erosion that results in an effusion in pro-inflammatory mediators that are present, and the persistence of these mediators are what become difficult to manage in these athletes. And then finally, with regards to specifically return to play, you have to account for not only restoring the actual knee joint, knee kinematics and strength around the knee, but their overall deconditioning and strength loss. Unlike ACL surgery, which tends to be a traumatic injury, which is followed fairly quickly with a reconstruction, these patients typically will have a long duration of symptoms, some sort of period of poor compensation, and a slow diminution of function over time. And that results in strength loss, proprioceptive loss, and some compromise with regards to mental factors. So this can be very challenging and should be considered. So what am I thinking in 2020 with regards to how to approach these types of patients? Well, here are the options. And I won't read the list per se, but I think with the biologics, we can start to ponder additional options in the realm of the non-operative type of treatment. I won't talk about corticosteroids. I don't think they have a real role in this area, but I am becoming more enamored with the use of biologic adjuvants in the long-term maintenance of the cartilage injured patients. We are all very familiar with hyaluronic acid. It's been around for a good 20, 25 years. And they are proposed as a mechanism because they are chondroprotective, anabolic, anti-inflammatory, analgesic, and also provide some mechanical relief. In a large meta-analysis in JVJS, they looked at 20 randomized trials where there were roughly the same number of HA-treated knees and placebo knees, and there were significant increases in pain and function in patients who were less than 65 with less advanced OA and typically one knee. And basically, the take-home message here is that for the early cartilage injured patient or the early osteoarthritic, there is a confirmed therapeutic efficacy of intra-articular HA, which I do use in a prospective, so almost like a preventative measure in the cartilage injured patients when we're trying to avoid surgery. What are the other biologic agents that we can use though? Platelet-rich plasma, bone marrow aspirate concentrate, and adipose-based stromal grafts. PRP has demonstrated good results in treating patients with cartilage lesions. Because of these local injections there, the injection of active growth factors, which are known to increase GAG synthesis as well as type 2 collagen synthesis and to lead to decreases in cartilage degeneration. PRP has also been demonstrated to induce chondrogenesis in mesenchymal stem cells. And typically, current commercially available preps will concentrate platelets 2 to 8 times compared to whole blood. And just keep in mind that for joint preps, leukocyte-poor type PRP are the best options. In this article out of Italy, they looked at 115 knees with degenerative cartilage lesions, which were treated with intra-articular PRP, and they noted between a 6 and 12-month interval, statistically significant improvement in all clinical scores. And so it was basically on the short term, PRP was seen to decrease synovitis and decrease pain, which was helpful. Obviously not a this review here is not meant to be a comprehensive review on biologics and PRP. I just want you all in the audience who do this type of thing is to try to think about revisiting using sort of less invasive measures in addition to adding these biologic adjuvants. So just sort of more food for thought than anything. Bone marrow aspirate concentrate is probably the most controversial of the group of adjuvants that we were typically using. This is simply just grabbing some marrow cells, typically from the iliac crest, in order to concentrate MSCs and HSCs and other endothelial progenitor cells in an attempt to create an anabolic environment where cartilage synthesis or repair may occur. In my clinic, primary uses for bone marrow aspirate concentrate really center around tendinopathy, but I do use it, as I demonstrated earlier, in palliative type procedures, chondroplasties, as well as an adjunct to the use of micronized cartilage and some of my autograft type procedures to allow for the treatment of larger lesions, as well as soaking the marrow layer for osteochondral allografts in BMAC prior to implantation. Not a lot out in the literature with regards to the use of BMAC for these indications. In this one study out of PM&R, it was 25 patients, again, 10 knees, 15 hips, kind of all over the place, quite frankly, that showed a significant increase in the Womack score with the added use of BMAC across these two joints. Again, I would posit to you there's really very little data on the use of BMAC as an indication for a simple joint injection, as opposed to some of the other preps that we talked about, namely PRP and hyaluronic acid preparations. So what about adipose stromal grafts? There's a lot of interest in this over the last several years, especially in Europe and the United States. And why would we even care about using adipose tissue? Well, adipose tissue contains high concentrations of certain reparative elements and reparative cells compared to bone marrow. Interestingly, the cell number and quality of these adipose-based stromal stem cells is less likely to decrease with age as compared to marrow-based cells, and they have 5,500 more cells exponentially compared to those found in amniotic fluid. So really, as a source, it is without question that the lipoaspirate is a better source if your goal is to try to concentrate as many of these mesenchymal stem cells as you can for the use in the cartilage injured patient. Specifically, we're looking to grab that perivascular cell that reside on the capillaries in these in this fat tissue, as they are very advantageously used in indication to control inflammation, in my estimation. So there are a number of studies that have demonstrated the potential utility of MSCs for the treatment of the cartilage injured patient. But what have some of these animal models, preclinical studies shown? Increased tensile strength of tendon repairs, increased load to failures in the rotator cuff healing model, decreased arthritis-related synovitis, and decreased scar formation. And in some very early clinical studies, mainly out of Korea, MSCs showed increased functional scores in patients treated with OA with a simple injection of MSCs, increased cartilage volume in those studies that focused on looking at post-injection cartilage volume by MRI, and in the treatment of epicondylitis, increased tendon volume. So again, nothing definitive, but definitely there is some strong evidence that adipose-based MSCs will be of some value to us as we move forward in treating these patients, hopefully less invasively, and we'll probably have more to report on that. We're doing a few studies here at HSS specifically on that area. Very encouraging, but again, nothing peer-reviewed at this time. So the palliative strategy is very simple. It's just basically trying to alleviate the mechanical symptoms that are associated with a cartilage lesion. You're not trying to attempt to do any type of reconstruction, and this is typically an in-season management strategy. Again, my colleagues out in Oregon have published on this in OJSM and showed that you can get, in a large group of in-season patients, increased function and improved PROs for all patients. And then they did note that of the 53 patients they looked at, about 15% did require reoperation, which I would posit is not a very high number. If you consider that even in the best of circumstances, typically good outcomes following cartilage repair is about 85%. The fact that we can get only a 15% reoperation in this very simple, straightforward, minimally invasive type circumstance should give you pause to say, wow, well, if we can do an in-season type management strategy, add an adjuvant to that may give us some fill in the area, we should probably cast an eye on this again and maybe revisit it. I would anybody who's trained with me knows that I am an extensive utilizer of post-operative imaging as an objective way to assess how I've done with regards to my cartilage repair strategy. I would encourage you that to if you're going to employ some of these minimally invasive strategies along with the application of some of these biological adjuvants, that you do the same. Typically, I would say for this type of palliative strategy with a biologic adjuvant, an MRI somewhere between 3 and 6 months after surgery, followed by a year to demonstrate a 2-point durability to your cartilage restoration strategy would be appropriate. And again, just showing this same set of x-rays, MRIs that I showed earlier as evidence thereof. Just going to hop forward here. So marrow stimulation. What about marrow stimulation? Is there still a role for marrow stimulation in modern cartilage repair in 2020? Well, you know, we looked at this. This is one of the main reasons that the HSS Cartilage Registry was formed back in 1998, because everyone was doing ACI and microfracture at that time. And my experience in the clinic with that, neither one of these were particularly great options. Well, one of the first studies that we came out with was published along with Kai Mithofer and the rest of the sports service at HSS, and basically it demonstrated that we had good, fair to excellent outcomes at 3.4 years, but that we found there were specific morphologic factors and demographic factors that correlated with good outcomes: BMI less than 30, symptom duration less than 12 months, lesion size less than 2 square centimeters, as well as an age less than 40 years. However, and you will hear this constantly, there was a deterioration of results that was noted across all demographics between 2 and 3 years, and even more concerning, there was no ability to predict who would get good fill. And this is typically what you would see. Year one, there would be a perseverance of the bone edema in the area on this lateral femoral condyle, and you can see by year 2 things look good with a fibrocartilage cap and a bit of bony overgrowth. And then finally by year 3, a loss of that fibrocartilage and a clear-cut development of bone edema associated with pain and dysfunction, which would always be very frustrating to those of us who were sort of treating these patients. If you look at a subset of high-demand athletes in the marrow stimulation world, the true return to play was only 22%, with again clinical deterioration noted in those even who had good early results between that 2 and 3 year longitudinal time period. Kai Mithofer did a meta-analysis looking at this particular methodology again. Look at 28 studies in over 3,000 patients, and again, same story, late functional deterioration, even in the good group, once you got past 2 years. So basically, in my mind, I've been very down on the microfracture procedure, mainly because of my early anecdotal experience with it, and then all the objective literature that has come out since that time over the past 20 years that basically demonstrates that in a head-to-head microfracture, by and large, always loses in these randomized clinical trials when compared to more modern cartilage type repair scenarios. So I would say the typical type of indications for this, lesions less than 2 centimeters, normal BMI, normal alignment, et cetera, are reasonable. But for those of us who really live in the world of subspecialty cartilage repair, it's really not applied, and I would just urge you to use caution. Whole tissue transfer. This is really where I cut my teeth with regards to getting into the cartilage repair game. Commercial allografts became available for use in 1998, and I immediately hopped on this bandwagon along with trying to teach myself how to do some of the more, they were kind of new at that time, hand-guided based mosaic plasty and autograft type osteochondral transfers. So if you're looking to predictably return athletes to sport, I would say these whole tissue type strategies should provide the mainstay of your repair strategies. In this study out of Norway, they looked at 40 patients with a mean age of 33 and a reasonable lesion size, and looked at these patients over 15 years. And in an autograft mosaic plasty, they demonstrated higher lysome skulls and PROs compared to microfracture longitudinally. In a study out of our institution, published by Aaron Critch, who's now at the Mayo, he looked at 48 autografts versus 48 microfractures in symptomatic cartilage injured patients, and found while there was no difference in functional outcome, there was a significant difference longitudinally of the Marks Activity Rating Scale, which persisted at 2, 3, and 5 years post-surgery, which basically, again, mimicked more of the same. Found in other studies that the early good results that you saw deteriorate with microfracture would persist in the autograft treated patients. This is an American football player presented with me with this early delaminating lesion as seen on the slide on the top left. And you can see down below with the picture looked at surgery. So that was treated with 2 autograft plugs along with the micronized cartilage grout, which was soaked in BMAC. I like to get kind of time 0 scans so I can understand kind of what we're starting out with. You can see in the top right hand that there's a very homogeneous and mature appearing cartilage fill in and around the plugs, as well as between the plugs where we put the micronized cartilage and BMAC. And most importantly, I think bottom right hand slide, you can see here that there's been an elimination of the bone edema that we saw early on that was associated with the lesion and the surgery. So the elimination of the bone edema is a good sign with regards to there being a lack of metabolic activity and likely pain. I love this procedure for my high demand athletes. I think the literature is very clear that longitudinally over time with regards to quickness to return, as well as the likelihood that they're going to maintain good results over time, this is probably your best option in the collegiate high school, patients who are basically under 30. If you can do it, I would strongly encourage you to do it. You will not be disappointed, and I've been very, very happy and pleased with this approach over time. Have not seen the issues with morbidity with regards to patellofemoral crepitus. I typically harvest these from the notch if I can, and I've extended my indications a bit by using some of the pre-cut allograft plugs as backfill and placing the autograft plugs in the area of the lesion, and we can talk about that during the question and answer later if people had interest. So most of you have heard me lecture many times on the use and utility of osteochondral allografts. I still love the allografts. They provide good results. Again, Aaron was very productive when he was at HSS. He demonstrated in my patients an 88% return to sport. Bill Bugby obviously has a very big experience in this area as well. Got back, again, same thing in the range, 75, 80% roughly return to sport over time, and about the same age group 33, 32 years of age. George Balad is one of our fellows, is now down in DC area, looked at just a very small set because I kind of wanted to know what was the real return to play rate in my pro basketball players, because I was kind of doing a fair number of these in these caliber athletes, and he demonstrated an 80% return to play at a mean of approximately 14 months after surgery, with a big range, right? 6 to 26 months, which I found was interesting, which again goes back to that kind of readiness to play requirements that are present with regards to restoration of fitness and mental factors. So the biggest issue that we had, quite frankly, was the persistence of an effusion. And again, we can talk about that too in the Q&A if you guys had a question. So this is probably one of the worst lesions that I ever treated. This is NBA player, had this horrific patellofemoral joint where I put in 2 25mm plugs, circular plugs, into the femoral trochlea, as well as one into the patella. He had this big beefy red synovium, which at the time I was wondering if I should didn't treat it. And then he ultimately was able to get back to play at around 10 months. Very, very explosive, very driven, kind of tended to the rehab very diligently, and was able to make it back. So, and again, 2 years post-op, you can see a maintenance of the graft integrity as well as incorporation of bone. So he was a big success story, which really kind of helped me to understand kind of what could be done. So what about biologics? I do use bone marrow to enhance the bone incorporation of these grafts. Dean Wong just published a study of our institution with roughly 30 patients that showed that it didn't change bone incorporation. Aaron Critch published a study looking at the old the old TrueFit plugs that did demonstrate an increase in incorporation with BMAC. So I think the jury is still out. My gut ear is that all things being equal, pulse lavage your grafts, soak them in BMAC for 5 minutes prior to implantation, and then I put a little bit of BMAC into the lesion. I think that the sum total here is, I don't think it's clear, quite frankly, whether or not the bone marrow is effective. I was very melancholy about publishing this, but the data is what it is. I just think that you lose little by adding this. So one study for the study with Dr. Cook out of Missouri shows that there was some utility to use it. So again, I think jury's still out, but my suggestion is if you're going to do an osteochondral allograft and have access to the BMAC, to go ahead and do it. What about cell-based? Where are we with cell-based? Well, you know, the ACIs are not available anymore. So what you really be talking about are ACI type strategies, which also bring in a membrane. So even before the MACI implant was available here in the States, it was available in Europe, and there is some evidence out there that the MACI implant can result in a return to sport. And so this one study in AJSM demonstrated that in a higher demand population with a mean age of about 35, they had a 74% return to sport to a pre-injury level. And again, probably most importantly, that even though all the PROs did go up longitudinally, the scores were durable. My biggest issue with the MACI is that the rehab interval is a bit longer than the osteochondral grafts, whether allograft or autograft. But they don't have the allograft options in Europe, so they were sort of, you know, pigeonholed into using this type of strategy. Again, good evidence here that it works. It just takes longer to get these good results. Another study at AJSM from a few years back, David Wood out in Australia basically published his prospective patients who he looked at and described as higher demand. And in this group, he did a MACI on either the tibia or femur. And so again, increases in the PROs, 93% satisfaction with pain relief, 90% satisfaction with ADLs at 5 years, and probably most importantly, an 80% satisfaction with sports participation at 5 years. So again, the MACI implant showing numbers with regards to longitudinal satisfaction that are in line with both autograft and allograft tissue. So good basis of evidence for athletics for the MACI. It's durable, two-stage, and it is available here in the US. So in my mind, the MACI implant, because it lives in the land of the autograft type tissue, the applicability may be better to use in patients who are, below the age of 30 or 35 years old, because the evidence here is that they have very good durability over time. I would probably say at this point, for me, this is what I think about if it's maybe a post-athlete or post-athletic career type person, sub-age 30. If they're asking me, hey, what is the most likely option for a large lesion, bigger than 4 centimeters squared, for example, that's going to get me through into my 50s and 60s. So good evidence here that the MACI implant is a very good option. What about particulate articular cartilage? Well, this became available about 7 years ago, and basically the idea here is that this is cartilage from young patients up to age 7. It's chopped and delivered to you in this little container, as you see it in the top right. And I primarily had some concerns about its stability in shallow lesions, but seems that the craters caused by these patella lesions were kind of ideal. So that's pretty much where I have used the Zimmer product. And again, a fair amount of literature out there, including some of my own, that shows that this was efficacious. In this study here by Tompkins, they showed that in 15 patellas at 2.5 years follow-up, all the PROs went up, and they had about an 89% mean lesion fill, which is outstanding, although they did report a couple of scope debridements for hypertrophy and stiffness. Jack Farr also did one of the early analyses of this type of methodology, and along with Brian Cole and some others, and they saw significant increases versus baseline of KOOS and IKDC and VAS with what they called good tissue integration, and mean patient age here was 37. Tim Wong, again, one of our former fellows, looked at 30 patellofemoral lesions from my cohort, and at a 4-year follow-up saw significant increases in the PROs, and 70% of the patients had at least 2/3 lesion fill with what our radiologist described as relative isointensity to healthy human articular cartilage. So again, my experience with this has been very good, but again, most of my experience has been in patellofemoral reconstructions. This is a patient, he's a former Nets player who was injured in game with a patella dislocation with this large delaminating lesion on the lateral facet of the patella. He also had a complete MPFL tear as well as a complete MCL tear. He ultimately underwent a medial patellofemoral ligament reconstruction, a primary repair, and a PJAK treatment to the patella. And he was able to return to play, shockingly, at 7 months. So just again, the older I get, the less I understand. This was not a particularly fit player. He didn't play a whole lot. He was, in fact, didn't like the gym, didn't like to lift. I'm pretty sure he was a smoker when he wasn't at practice. And this case I did about 5 years ago. He since has gone back to Russia, but was the MVP in the Russian league 2 years ago. So again, good option here for patella lesions. I'm a little more circumspect in other areas, but clearly very good option if you're seeking a cartilage repair option that will allow you to get some sort of type 2 collagen type repair. So if you look at the meta-analysis, they're all basically saying the same thing, that if you pool all the data, all the methods that I've mentioned, say for microfracture work, the Oss procedure, 93% return at 5.5 months. Osteochondral allograft, 88% return at 9.6 months. And ACI, MACI, 82% at 11.8 months. Microfracture, a little over half, typically at 9 months. But again, if you're lucky enough to be in that good group, the 58%, you always see a diminution of function between 2 and 3 years. In another meta-analysis, same type numbers, running somewhere between 80 and 90% for the primary three, as I'll call them, with microfracture running distant fourth. So here's really the algorithm. There is no established algorithm, but here's what I think about. Cartilage defect, you have to think about how you're going to do your surgical reconstruction. Think about then how your rehabilitation is going to include the restoration of knee kinematics and the correction of joint hemostasis. This is where I think the biologics play an important role. If I think you have a lot of pre-surgical inflammation, synovitis, I may add in adipose stromal graft at the time of surgery. If at 3 months I noticed you remain with a significant effusion, I may then suggest a course of platelet-rich plasma, which I'll usually do over a month's time, 3 aspiration injections with leukocyte poor PRP in an effort to treat it. So that's really it's a read and react strategy. Not every patient's the same. The degrees of postoperative swelling are not always the same, but you need to have that in mind as you're kind of getting down the rehab pathway. So once you've been able to correct that, then it's really more of a focus on decreasing pain, increasing function, increasing fitness and strength as you try to objectify these measures with regards to counseling patients as to whether or not they can return to sport. And again, not a lot here to guide us in the literature. I rely heavily on some of my embedded therapists at HSS because they see the vast line share of these athletes who I bring in, even if it's on a one-off basis to evaluate them. We use the DARI, we use hamstring strength assessments. We really kind of dig deep on them with regards to creating some side-to-side measures as well as some population-based measures as to when is the right time to allow them to go back so they're not bouncing back to me with recurrent swelling and pain. So with that, I'll stop and happily sort of engage anyone in the audience on any questions they may have.
Thank you, Dr. Williams. That was tremendous. Really appreciate it. We do have a few questions. Going back toward the beginning, the concept of MSCs that you were discussing, whether they're BMAC or amnion derived, I think for the layperson, they hear stem cells or they're maybe marketed to believe that when you're discussing stem cells, you're talking about regrowing, regenerating. I'm gonna have the knee of a 25-year-old again. And I know in the medical community, there's even some debate or discussion around, are they stem cells? Are they signaling cells? What do you think those cells, what role are they actually playing when they do have that positive impact for patients?
So I know we flew through it, but here's the reality. When I speak to patients about these, signaling cells, this is actually a more accurate way to describe them. It's seldom about tissue regeneration. There's really very little evidence that these cells that we're harvesting have any effect on tissue regeneration. The few studies that I came across really were more in the area of tendon and tendon injury and tendon regeneration. And there's some, I'd say, soft evidence there, but certainly nothing that you could hang your hat on as it being definitive. In the area of treating joints and cartilage lesions, again, no literature, no evidence to suggest that the injection of adipose-based mesenchymal stem cells or signaling cells cause cartilage regrowth. But what is clear and noted on repetition, and it also fits with my own personal experience, I've probably done a couple hundred of these over the past 5 years, is there is a marked diminution of joint inflammation and effusion associated with the use of this material, unequivocally. As a endpoint metric, it's very hard to quantify an effusion. It's a visual assessment. You can do serial MRIs, but again, it's more qualitative than quantitative. So I found it a little hard to report on that phenomena. But we are getting there. Some of our own internal studies have demonstrated that there are clear-cut lineages of stem cell populations in the aspirate that are elevated versus other tissue sources, including whole blood and bone marrow. So while I think there is utility in the adipose, as long as clinicians are clear with their patients about the attempted or the desired effect being sort of an adjunctive anti-inflammatory effect as opposed to a regenerative effect, I'm very comfortable there, but I have zero expectation, nor do I suggest to patients that this is going to regrow anything in their body.
That's great, thank you. And I apologize, I think I misspoke and maybe mentioned amnion instead of adipose, but thank you for speaking to that. We have a few questions that are all sort of tied to the concepts of autograft and allograft Oates procedures. Then, for an autograft Oates procedure, does the is there a size limitation? Is the question? Does the size of the lesion help dictate, or is it more the bigger picture of the patient and what they want to return to?
The old guidelines or dogmatic used to say, 2 by 2. Personally, I think that's probably a little small. I'm very comfortable harvesting 10 millimeter grafts. You can usually get 2 off of the medial lateral condyle notch area, such that it doesn't interfere with the joint loading surface, and maybe 1 up off the trochlear ridges. But again, as I mentioned in the talk, I've really taken to backfilling those large plugs, and to me, a 10 millimeter autograft is large with a 10 millimeter allograft. My thinking being, I'm going to take this allograft plug, which may biomechanically not be as good as my autograft, and put that in the less demand area, and then take my autograft and put that into my area of load. That has enabled me to treat much larger lesions in that 3.5 to 4 centimeter type size area, as opposed to the traditional 2. But it really depends. If you're talking about a small woman versus a large football player, I mean, surface areas of knees are germane to the amount of donor tissue that you'll have available when you're trying to size these lesions. The micronized cartilage product, which is commercially available from a couple of different vendors, is a nice way to create a grout around lesions so that you can extend your indications. I think that what you have to sort of do is get comfortable with the idea of maybe using the pre-cuts as a backfill. I've not noticed any issues, as I mentioned before, with crepitance or patellofemoral issues noted that have been traditionally associated with mosaicplasty or autograft harvest, especially off of the trochlear ridges. And be flexible. You need to template these things out, use your preoperative imaging and MRI studies in the office to sort of see where you think you sit, and be honest with yourself when looking at these studies, like where does the good tissue start and the bad tissue start? Because those MRIs can oftentimes underestimate lesion size, because as we know, the lesions are seldom well shouldered. They're usually graded lesions that go from a grade 4 up to a grade 1 or 2 with some degree of erosion there. So, practice makes perfect. Repetition will help you. But certainly I would encourage anybody who's sort of thinking about this to consider doing an autograft in those types of circumstances where you were traditionally taught to do a microfracture, and then you kind of get comfortable from there.
That makes sense. And so we did have a couple of questions around that, the concept of using the autograft plugs to fill the lesion, and then allograft plugs to backfill the donor site. So as you mentioned, then the biomechanic difference in your mind, the biomechanical difference would be just so that entire unit, knowing that coming from the autograft site, there's no concern for cartilage delamination, or more specifically the biomechanics? What would be the advantage?
It's it's very simple. You autografts are known to be durable.
Got it.
And you're just basically putting the tissue, which may not have as good mechanical qualities. I'm not saying the allografts don't, but I'm just saying I've seen allografts delaminate. It's hard to know what the specific circumstances are for that. So in my mind, I'm like, all right, well, like I believe that autograph I showed was in a professional football player, it was like a kicker. So clearly that area of the trochlea was an area of high load, right?
Yep.
He does not want a TTO. He wants to go back and play football. So the forces that led to the degeneration of his own tissue are still there. So, okay, fine. He wants to play another few years and make some millions, and I get it. So I want to put autograft tissue there because I know that the biomechanical circumstances in and around that lesion still exist. Now, if I had done some sort of offloading TTO, then maybe I'm like, hey, we can just put an allograft here because I'm not worried about the biomechanics. So if I'm, that's why I like to do these talks in the framework of high demand, right? Because
sure,
we're not going to have all these tricks of the trade with regards to osteotomy available to us in these athletes. So you need to have kind of clear-cut thinking in and around what you're doing. So all I'm doing in these circumstances is putting what has been demonstrated to be the strongest tissue into the area of potential high load, and then you protect the knee by putting a nice articular cartilage graft into the area of the donor, and that decreases the likelihood of any kind of postoperative morbidity that's typically associated with the autografts. It's a slick little way to do a hybrid procedure and allow patients to get back to high demand stuff relatively quickly without some of the side effects.
That makes perfect sense. Thank you, Dr. Williams. A couple of questions regarding osteochondral grafts in the patella. Is there a role for either autograft cores being placed in patellar lesions or the pre-cut allograft cores?
I'm sorry, Christian, you kind of cut out there for a second. Could you repeat that again? Sorry.
Yeah, sorry. The question is really, is there a role for autograft cores or potentially even the pre-cut allograft cores in addressing patellar lesions?
Oh, yeah, definitely. I think that is, the 16 millimeter cores were developed mainly out of two thoughts. One, most patellar lesions, say for example with a dislocation episode or an early degenerative lesion, can be treated with a single 16 millimeter core. And then most chondral lesions can be treated with either one or two adjacently placed cores. So that was, purposely picked out that way. And the answer is yes. The only, people have some concerns because you're using oftentimes these pre-cut cores that are harvested from a condyle and putting that into a patella. And if you image it, there's clearly always a difference in the cartilage mantle between the two. But just so everyone is clear, there are a few studies out looking at specifically in this. It does not appear to be any correlation between the cartilage thickness of the donor tissue and clinical outcome. As long as you fill the defect with healthy articular cartilage, whether it be autograft or allograft, seems to do fine. So the answer is yes. The sort of pearls there, though, is you obviously have to evert the patella. You cannot do a sort of traditional impaction type harvesting method on the patella. You always have to use a guide pin and a reamer to create your host defect. There's a nice system from Arthrex that I was involved in developing that goes along with the 16 millimeter cores that purposefully has a very low kind of insertion tolerance so that you're not hitting on these grafts. You should be able to insert them digitally. The real trick here is really kind of establishing the right depth. So because once you put the grafts in, you can't take them out. But to cut to the chase, the short answer is yes, you can, and you should, because I think it's much easier to get a 16 millimeter pre-cut than it is to get a hemicondyle and trying to figure out where in the condyle to take a graft.
That's great. Thank you. One last question, sort of related to both the autograft and allograft plugs. And this may not be as big of a factor with the patient population that you tend to see, although you're treating large American football players also, but is BMI a concern? Maybe for the surgeons and the reps working with surgeons who are treating the average layperson again, are those BMI restrictions clinically relevant, or do they tend to be insurance policies?
Well, I mean, listen, I think that begs a larger question. We seldom say it, but I'm just going to say it out loud. I mean, what we're treating are early degeneratives. That's what cartilage repair is. So clearly, someone with a high BMI is going to be at increased risk for higher loads, just like anybody would be, say, for example, who's in varus malalignment and you want to do some sort of mediofemoral condyle type reconstruction. In general, you'd like to be below a BMI 35. I think that's where most folks in my at least practice live, and you want to correct malalignment. So I had a spectacular failure of a graft in a very high profile baseball player, mainly because I let him talk me out of doing the osteotomy that everyone knew he needed. So I think you have to be very clear-minded about what you're doing and what the physiology of the repair is and what the loads are going to be subsequent to the patient feeling good. Osteochondral allograft patients back in 2000 were godsend to me because they were the first patients I ever experienced who actually got better after these procedures and got better quickly. And that's fine. They'll all get better. And I don't think the surgeries are very difficult. And I think if you're doing cartilage repair, you should definitely consider osteochondral allografts. They are really good surgeries. They're a good procedure, low morbidity, and are typically effective. However, you have to just be very, very aware that you never really get rid of these people, and that 4 years later, 5 years later, should they not really attend to a lot of these corrective fitness measures or these corrective strength measures, they'll damage the graft, or there'll be some progressive arthritis in and around the area. They got some new lesions, so you never really rid of them. It's almost like treating diabetes. So that's just the perspective I have now, whatever 23 years later, about what you're signing up for. So I happily enter into these relationships with these folks knowing that it's going to be a long-term relationship. But at the end of the day, it's very hard to cure them, regardless of which one of these methods that you wind up utilizing. Is really more so like, okay, you have to kind of keep in your mind, like, how can I optimize their recovery to try to mitigate or minimize the recidivism and revisits that ultimately come with a large number of these patients.
That's great. Thank you. We've got a couple more very good questions here with a few minutes to go. Question here is, have you utilized mature cartilage matrix, so for example, biocartilage, augmented with autologous cartilage cells collected during the procedure?
I'm sorry, Christian, you went out one more time.
Oh, I'm sorry. Maybe connection issues. Have you utilized cartilage matrix like biocartilage augmented with autologous cartilage cells collected during the procedure?
I have not. So biocartilage is micronized, dehydrated, articular cartilage matrix. That's what you saw in the picture I used mixed with the BMAC to extend the indication for autograft type procedures to treat larger lesions. I've not had experience with the intraoperative harvest of cells and reimplantation, or of cartilage matrix and reimplantation.
Okay. And so that's potentially an area of interest for surgeons, I'm sure, to just as they were asking, augmenting that dehydrated matrix with potentially some chondrocytes from the patient. Another question here is, how do you address partial thickness chondral lesions with underlying bony edema? Osteochondral auto or allograft or subchondroplasty?
Okay, so I mean, that question has lots of layers. So you have to really kind of think about and establish in your mind what is the cause of the edema. Meaning, is it a malaligned knee, which is now finally getting to a point where the cartilage is starting to erode, but that the edema is essentially the first harbinger of overload? Because then the answer is an osteotomy, right? If you've got partial thickness cartilage. If it's on the tibial side and you don't think you can treat it, I certainly have used intraosseous injection of calcium phosphate mixed with VMAC as an option effectively, like a subchondroplasty. So I don't think the question there's one particular answer. The circumstance where I typically will do an autograft, for example, is in the cases of OCD lesions in adolescents and young people who have failed non-operative measurements, and I just want to import some healthy subchondral bone into the area of bony abnormality or edema to drive a healing response. So lots of different permutations of where you can see that type of situation, but my counsel would be get a firm grip on what you think the cause is, and then what your options are. In general, I don't treat partial thickness lesions unless I think number one, the loading characteristics of that lesion are poor, and that has to be treated. If you're embarrassed and you're starting to have this issue on the MFC, then you got to treat the varus, right? I'm not going to go in and do a cartilage repair procedure on a partial, because everybody knows where that's ultimately going to go. And again, that's sort of what I was driving at when I mentioned the failure with the baseball player.
That makes sense. Thank you. So maybe with just a couple minutes to go, if you don't mind, for maybe the final question, I'll bring it back around to osteochondral allograft for just a moment. We have with us today some folks who work with JRF, some industry reps, Arthrex representatives, as well as surgeons. Osteochondral allografts can be logistically challenging, right? Scheduling, communication, those kind of things. Any pearls that you have in terms of working with your team, your clinical team, your industry reps, the tissue bank providers, the tissue providers, on communicating effectively and trying to handle those logistics?
Yeah, I mean, I think the double-edged sword of osteochondral grafts is, we spent basically 20 years trying to demonstrate their efficacy, which I think in the knee world, most people are comfortable with the idea of doing a graft. It's really graft availability that has become the limiting step. I'm very pleased with the pre-cut program. I will say that personally, they're easier to get, and if surgeons think, listen, one or two of these based on my lesion size should be able to treat it, you immediately are able to increase the supply, which may kind of get in the way of many surgeons having these. So the pre-cut 16s, in my mind, and hopefully we can get to 20 at some point, really should be the primary treatment strategy for most lesions. And like I said, just personally, I like the 10 millimeter backfills for autograft type scenarios. Engage have surgeons engage. You guys are great. I've had a very good experience with JRF over the years. Very proactive and surgeon focused. The pre-cuts also provide some flexibility as well, because you don't require all the instrumentation and trays that you made with the hemicondyle option. It just takes some time to get good at receiving a hemicondyle, processing it, harvesting from the right spot, et cetera. Again, the more you do, the better you get, as with any procedure we do. But you have to just basically, in my mind, jump into this arena with 2 feet, decide that you want to get comfortable with the procedure. I remember my first procedure I did in whatever it was, 98, I think it was. I mean, the patient must have had a 1 foot long incision and a massive arthrotomy for this little plug. And each year, got smaller and smaller. So now I basically do it just as with almost, with an incision just barely big enough to get the graft in. So, embrace it, understand it, and the more, just understand that the more you do, the more likely you are to get tissue.
Those are wonderful words of wisdom. I want to thank you again, Dr. Williams. It was really a privilege to have you join us today, and thank everyone online for joining us as well. And with that, we'll go ahead and close the webinar, and hope that everyone stays safe and healthy out there. Thank you all.
Great. Look forward to getting back to some sort of semblance of normal soon, guys.
Absolutely. Thank you.
All right. Take care.